What we're going to do. So welcome back. We're going to continue with our last two panels of the day. As you know, we're talking about healthy, wealthy, and wise, the future of healthcare in Texas. I have a great panel here, and I'll introduce the moderator in just a moment. But to continue our education of Nacogdoches and Texas history, we have a visitor with us here today, the country doctor. And there's a great bronze statue in front of Memorial Hospital on Mound Street of the doctors who have served this area. The old the picture of the guys with the bags going out in the middle of the night and riding their horses or the buggies, and that's a tradition that was is a rich part of the heritage of Nacogdoches. And so, with no further ado, I'm going to introduce the country doctor, Dr. James Harper Starr.
Good afternoon. It is not the year you think it is. This is now 1860, March the 3rd of 1860, and I'm Dr. Starr, who was a good old country doc. I came to Nacogdoches about 23 years ago, in 1837, and began practice of just general medicine. And it was very difficult at those periods of time because, one, I did have to go out into the country. I do go out into the country in my horse and buggy. In fact, I'm scheduled to go out this afternoon to Chirino and pull a tooth. But I have to go house and buggy, and I did everything out there. I do dental work, I do surgery on a kitchen table, I deliver babies, and not with much more equipment than what I've got in this bag. So it was hard, and the worst part of it was I didn't get paid. I don't get paid very well. I'm dropping everything on the table. You would charge for the visit, but you couldn't make much money doing that because, first of all, Nacogdoches was not very affluent financially. I could probably get 50% of my charge. And so what I do is what most doctors do now is I charge for mileage, and I charge for distance, and I charge for medication. Right now, I'm charging 25 cents a mile and 15 cents a gate to go see you out in Chirino. Now, that takes a while. And I also charge for the medications, which I carry with me. But despite that, I don't make much money. So early on, when I first got here, I realized that, and I tried a little bit of politics. I was a land commissioner here in Nacogdoches in the 1840s, and I was appointed by President Lamar to be the state secretary of Treasury secretary. Well, I did not like politics at all, particularly that guy, Sam Houston. Sam Houston was not a friend of mine. I wasn't in favor of what he was doing, and so I decided to quit. I came back here to Nacogdoches and practiced family practice, general medicine. I was active in the community. I was probably single-handedly the most important person in getting the railroad to come to Nacogdoches, and I was very much involved with the building of what I call the new university, built down closer to town, and it opened in 1845. I still serve on the board of trustees of that institution. But even with all of that, and I was real popular, everybody talked to me and asked me to come see them, but I wasn't making any money. So what I've decided to do at this point is I'm going to keep practicing medicine, but I'm going to branch out a little bit. I understand that bankers do real well, and I understand that real estate people do real well. So I'm going to go into real estate and banking to at least be able to break even on my practice. So I have to go on my way to Chirino here, so I want you to know that I am available. If you have anything happen to you while you're here today, just give me a shout. But remember, it's 25 cents a mile and 15 cents a gate. Have a good day.
Doc, you may need to stick around. If I keep talking, they're going to need some smelling salts to wake them back up. But thank you. I will also mention near where the statue is the Oak Grove Cemetery, one of the oldest cemeteries in Texas. Buried there in the obelisk is Thomas Jefferson Rusk. And if you recall, we have the U.S. Senator line, we have the Houston line, and the Thomas Jefferson Rusk line, and he's buried at the Oak Grove Cemetery. Great place to go visit. They did just put a new fence around that cemetery because people are dying to get in there. Oh. I'm sorry, I couldn't resist that one. Couldn't lay off the highball. All right, so at this time it's my pleasure to introduce a guy who's pinch hitting for us. He's certainly qualified to handle this panel as our moderator. Kevin Warren is the Executive Director of the Texas Healthcare Association, which, as you can see, is our presenting sponsor of this event today. But he also did this on short notice because I think I mentioned Scott Street at the hospital, the CEO of Memorial, came down with the flu bug. So I see our CEOs there at the back of Medical Center in the back. They seem to be quite well. I'm not going to comment on what that may mean. I'm just saying. So great to see you guys here. This is an issue of great interest. What does healthcare in Texas look like? And so instead of listening to me, Kevin, come up here and take us away.
And again, as a presenting sponsor, I want to thank you all for the opportunity that we've had to spend this time with you all, and I hope that, as I've heard time and time again so far, this not only this morning and last night, but this afternoon, just the value of the program. I want to just jump right into it. As Representative Clardy said, I'm Kevin Warren, CEO of the Texas Healthcare Association. We're the largest long-term care association in the state of Texas. We serve provider members, skilled nursing, post-acute, and assisted living across the state of Texas. I think we're in every single Senate district, and I believe every district in terms we have members, all but I believe 10 to 15 House district. So enough about me. What I'm going to do is I'm going to introduce our panel in order of starting from me and then moving out to Representative Capriglione. And at the same time, after I introduce you, I'll start, Senator Colcourse, with you, and I'm going to ask an initial question, kind of a kickoff question, and at the same time, as part of that question, kind of give an intro or a background as a bio of yourself as we can get going. So first to my immediate left is Senator Lois Colcourse. She is from Senate District 18. To her immediate left is Executive Commissioner Chris Traylor. Sitting next to Commissioner Traylor, we have Representative Donna Howard, who represents District 48. And then at the far end, we have Representative Giovanni Capriglione, who represents House District 98. So again, Senator Colcourse, I'll start with you. And as I mentioned, I want to start with a broad question about the state of healthcare in Texas. How do you see the state of healthcare in Texas today, and in particular the state's preparedness for managing current health needs and our readiness for the future? Where do you feel that we are succeeding, and where as a state do you see that there are gaps that we have got to address?
Well, thank you for the question. First of all, I want to say thank you for allowing me to be here today. I got this invitation to come to East Texas, and I can't tell you how much I love being here and how beautiful it is. I want to give a shout out to Senator Nichols, who I serve with. Senator Nichols and I go way, way back to killing the Trans-Texas Corridor, and so I want to say thank you for his work. But I also noticed how many highways are being improved, Travis Clardy, as I drove in yesterday, and I know you have something to do with that as well. So a shout out to my East Texas brethren and friends and colleagues, because I'm a rural lawmaker and I work pretty hard for those rural issues, and I know that those voices have to be heard as we become more and more of a urban, suburban kind of state. So with that, I want to say thanks for letting me share a panel with people that are much more smart. They're smarter than I am, but I'll just give a quick answer to that. Texas is growing. We're a huge state, but we're also an aging state. And so when you see an aging state in ways of our baby boomers moving into those latter years, we're going to have the different models for long-term care that I know your association deals with. I have some statistics here. Chronic disease accounts for about 75% of Texas's healthcare expenditures. You have I call them all the P's, the possibly preventable hospitalizations that cost us $91 million in FY 2016, and that was for Medicaid. You have a sixth of the Texans use tobacco, a third are obese, two-thirds are overweight, 2.5 million have diabetes, 7.1 million are pre-diabetic. You have hypertension that impacts 25% of us, and you, of course, have the behavioral health issues. And so with all of that good news, I will say that we have our challenges. It's expensive, but it's not exclusive to Texas. You see this all across the country. Guys, in the budget, you hear it in the presidential races. We're talking about how we move forward with the Affordable Care Act. Do we keep it? Do we scrap it? How do we move? What do we do next? And my concern has always been, and one of the driving issues for me is, in the end, the cost. You look at Medicaid and Medicare and the drivers that they are in the federal government and also in our state budget, and they're unsustainable. They're truly unsustainable if you want to have a vibrant public education system, a higher education system, if you want any money left over for transportation, and the other panels that have met with us. So today, this panel is going to, discuss, I think, the crisis of not just Texas, but all of the United States and how we pay for health care moving forward. And there's no simple solution because every system, every hospital that is represented today, every long-term care facility that is represented today, they are built on a model that started in 1965 with Medicaid and Medicare. And so how do you make those changes? And all of them, every time you say, we're going to do something different, and they say, well, we've got all this debt. You can't make that. Don't move my cheese. You can't make that change because of that business model is going to hurt our, we're not going to be able to make it and sustain it, and we're going to close hospitals and do these different things. But like the education panel talked about, the modernization of public education, healthcare is very modern. The thing that isn't modern about healthcare is the payment models. Why is this instrument, it continues to go down in healthcare, in prices, but nothing in healthcare goes down, nothing. And it's a lack of transparency. The consumer is not engaged on what the total price of healthcare is. You don't walk in and say, hey, doc, what's that going to cost today? You say, hey, what's my copay? And you go from there. When you look at Medicaid and Medicare, it's exasperated because somebody else is paying the bill. But we can't keep borrowing money. We cannot keep borrowing money to pay for health care in the future. So I've been on this public health rampage for about 8 years now just because I'm a numbers person. I look at the trajectory. And while we have responsibilities as human beings to be healthier, we need to cut out the president of MD Anderson told me if you get rid of tobacco in people's lives, you eradicate over a third, maybe closer to half of all cancer. Wow, that is a sobering number. That is something we need to be looking at in those incentives. So that's where I think we are. The budget is big. It continues to be big. I am pleased about the mental health monies that we have put in, and I want to brag, and I'll pass it on to my colleagues. Senator Jane Nelson put in a rider in this last budget. It was put in Article 9. It was put in late. We just had a hearing on it, and it was a rider that talked about mental health monies, and it made every agency report any mental health monies that they get across all spectrums, all what we call the articles of the budget. And then she put together, the rider directed that everyone that received money had to start meeting and talking about how they were spending their money because we're looking for duplication of efforts. And it's billions of dollars that we spend on health care. We can't even get the amount, Chris, from Medicaid on how much we spend on mental health, or at least the last hearing we didn't have it, but he's writing me a note. And it's $1.2 billion on mental health in Medicaid alone. So now we're over $3 billion, $4 billion total in a biennium that we spend on mental health in the state of Texas, and we didn't even know it. So if we can figure out where all those monies are going and make sure that they're going to the right people in the right manner at the right time, I think that we can do a better job with your taxpayer dollars. So that's my thoughts for today.
Thank you, ma'am. Commissioner.
Well, thank you very much. And I kind of look at this as like a Charles Dickens novel with healthcare. It's like this is the best of times and it's the worst of times in many ways. And what it represents is really a system in transition, our healthcare system is. Yeah. There is an extraordinary opportunity in the healthcare system, not just in our state, but in our nation. As we look at our high utilizers and high cost persons that utilize the healthcare system, you look at what you can compartmentalize those costs, and you look at it. It's hospitalizations, mental health issues, all those things that we can address in our healthcare system, and we're really at a confluence of times when, for example, people that return to the hospital for readmissions, 60 to 70% of them, depending on where you are in this state, have a co-occurring mental health issue that contributes significantly to their return to that higher cost setting in a hospital. when we invest in mental health dollars, as the legislature has invested significantly in the last session particularly, we have the opportunity to address those mental health needs in a way that can divert some of those inpatient hospital stays. When you look at the Medicaid program, 25% of people that are enrolled in Medicaid utilize 60% of the dollars.
Say that again.
25% of persons that are enrolled in the Medicaid program utilize 60% of the services or the dollars. And fortunately, Texas, and I'm not sure Texas gets a lot of credit for this, but Texas has been one of the first states that recognizes the links between long-term care, long-term services and supports, nursing facilities, home health, and acute care services. And we've integrated those two in a model that allows us to incent cost savings. And that cost savings, in my view, has as just as important an element, and that's improvement in the quality of people's lives. If we can create a system that the financial incentives and the quality of life incentives are aligned, we can create a healthcare system that benefits our citizens, our taxpayers, and the families of those individuals that have a chronic health care need, a long-term health care need. We're at a confluence right now of all those issues are coming together in one place at one time. Mental health, long-term care, acute care, including hospitalizations. And we have an extraordinary opportunity to align our payment structures in a way that somebody, an entity, is responsible for all those elements of care for a person. It's like to say around the office, if you have more than one person in charge, there ain't nobody in charge. We can develop a healthcare system where those incentives are aligned, the consumers that have the cognitive ability to make those choices can make those healthcare choices, and then you can also have the financial resources aligned in a way where cost containment and quality of life meet. I believe we'll have an outstanding healthcare system for the future. Nobody has cracked the nut yet on how you pay for that exactly. Whoever in this space is able to figure out exactly how to align those incentives will be the big winner in the healthcare system for not just now, but for many, many years in the future. I'm not smart enough to figure it out, but the system itself over time will figure it out, and I believe that we'll have a greater healthcare system that aligns with the consumer preferences of the 21st century and not necessarily the early part of the 20th century, which, as Senator Kolkhorst pointed out, there's still a lot of the old paradigm mixed into our current system. When we transition out of that to the future, I believe healthcare outcomes and cost will be aligned in a way that people and families have better healthcare, better lives, and better outcomes.
Thank you, Commissioner. Representative Howard.
Well, they've already covered many things, and I think kind of laid the groundwork for how complicated this is and how many factors are at play when we're talking about what the current status is, where we're going to go, how we're going to pay for it, what some of the main issues are. But I think one of the things, and I know we'll probably talk about this a little more, one of the main issues, of course, that we've been dealing with to some extent, or not dealing with as the case may be, is the fact that we have such a large number of uninsured Texans. That does impact access to care. There's other factors, of course, as well that impact access. But the fact is that we have in Texas the largest number and the largest percentage of uninsured of any state in the country. We have about 5 million people who are uninsured. That's gone down since the Affordable Care Act went into place from, I think, about 22% to 19%, something like that. But we still have situations where we're going to be providing health care without a mechanism of reimbursement, if you will, that is requiring our local jurisdictions to foot the bill, increasing our property tax burdens, also increased premium costs to those of us that are insured to cover that. So one way or another, we're paying for it, and of course, we will, as I'm sure get to this later, foregoing certain federal dollars. that could be used to help us offset some of these costs. There's a lot of arguments about, oh my gosh, we can't take that money because, it's not sustainable and we don't trust the feds to keep up their end of the bargain. And okay, that may be the case, I don't know, but we've gone now a couple of years with the federal government supplying these dollars to other states that we're not taking advantage of, and these are dollars that are due our state, but we're not getting them. We hear from chambers of commerce, from all kinds of professional associations, the Texas Association of Business, that we need to be looking at how can we address this. And I look forward to talking about that a little bit more, but I do want to just refer to a couple of other things. When I'm talking about access to care, of course, that also has a lot to do with the providers that we have, and we have a provider shortage in our state that no matter how many people were covered, if you don't have adequate providers, they're still not going to get access. So I know Senator Colkhorst has worked on this, as have I, in terms of trying to increase opportunities to get more nurses in particular through the pipeline. This last session, we also put more funding into our graduate medical education program to ensure that those medical students who go to school here in our state have opportunity to stay here and practice by actually having residency slots. So we're moving, I think, in a better direction there as well. But another thing that exacerbates that are our reimbursement rates. And we reimburse with Medicaid is at about 2/3 of the Medicare rate, around in there.
Yeah.
A lot of primary care providers, physicians in particular, can't accept that kind of low payment and cover the costs of their operations. And so even though we may have X number of physicians who have at some time or another taken Medicaid patients, they're not taking new patients. And we're limited in where these patients can go. So we have a lot to address there. I think the transparency is, of course, part of the issue too, as Senator Colkhorst mentioned, but I think we also have other factors that are at play here. And I think the transparency thing, I personally feel like I'm a fairly educated person. I'm fairly intelligent. I work in the government, and I know about how some things work. And yet I find myself, when I am put in that position of being consumer and having to search the market and figure out how I get my energy, how I get my telecommunications, how I get my insurance, how I get all the things I'm supposed to be figuring out here, that's a hard thing a lot of times, and it's hard to know how to navigate that whole system. I think transparency is good, but I think we have a lot to do to make it navigable and understandable so that it's not just numbers that are sitting on a page that somehow the consumer is supposed to decipher. Anyway, that's just one part of that I would say. We have a big issue with our chronic diseases, as Lois mentioned. That's going to be a very costly thing for us to continue to work with. We've got to do more in the area of prevention. We have huge pockets of populations in our state with diabetes. We have changing demographics that are contributing to that we've got to address. We still have a huge problem with teen pregnancy and repeat teen pregnancy, and we know the vicious cycle that gets us into, and the costs to taxpayers as those people are unable to get out of that cycle of poverty that they are continuing to find themselves going around and around in if they have children and when they're not ready to be able to take care of those families. And Commissioner Traylor here knows that I'm focused a lot on women's health care. We've had lots of discussions about this, and we still have some challenges there. We're working on a consolidation right now that hopefully will result in delivering those services in a way that we can meet more of the needs of those who need those services in this state. But clearly, family planning is one of the most significant public health events of the past century. When we had family planning come into place and families were able to determine when they were going to have children and space those children, it decreased the morbidity and mortality of both the mothers and the infants. It has been a huge benefit to society, and we have made a situation by some of the cuts that occurred in previous sessions and some of the programs that had to close down, we have made it more difficult for some people to access these services. And in the long run, again, not only is that costly to that family, it's costly to taxpayers. I think it's half of our births are Medicaid births that we pay for as taxpayers.
53%.
Yeah, a little more than half. That costs us. Costs a lot more to pay for that pregnancy and the first year of that infant's life than it does to pay just a couple of $100s for some contraceptive care. So there's a lot of ways we could be looking at this. There's a lot of issues, and that's, I'm jumping all over the place. It's hard to know where to go after they've covered a lot of the stuff here. But I look forward to having some more discussion here. Thank you.
Thank you.
All right, so I'll do all the rest. All right? I'll
Okay.
do whatever is left. My name's Giovanni. I'm not a doctor, but I'm involved on the budget side on the Appropriations Committee. And when I first started running for office, I used to carry around a budget pie chart. And the biggest part of that pie chart was education. And I would say, look, this is the biggest part, and health and human services was second. I can't do that anymore. If you include supplemental funding that we put in the Texas budget in the last session, it's already, healthcare is already larger than education, and this budget as well, and it's just going to continue to grow, and it looks like it's going to continue to grow for a long time. And what that means is that regardless of how and who's going to be writing that check, it's going to start putting pressure on the other parts of our budget. That's education, that's transportation, it's public safety. And so as we work on this and we look at Texas, which is growing, we're having to figure out why these costs are growing and how we can minimize them. And that's why we have this conversation about whether we want to accept funding for certain things and if we want to be on the hook for those things. It's not so much, hey, what is it going to cost us today, but what is it going to cost us over the next 10 years, 20 years, over the next generations? When the good doctor started off his conversation from the 1860s, he talked about how he would have to go places, he would have to go and diagnose the person, prescribe them medicine. Well, 150 years later, that's still how medicine works. It's still very labor intensive. And when we see, and we talk about, well, why is healthcare always so expensive? Because other industries have been able to use technology to reduce the labor costs, but in healthcare, that's not happening. So the one way to look at reducing the cost is to figure out how to prevent people from using it as much. And when we talk about low-income individuals, for instance, which is where when we talk about Medicaid expansion and other things, the ones who are the most not getting that insurance, we have to look at what could be the best return on investment to be able to take care of those health needs before they occur. I know in other states, and I know we do to some extent, but I would offer as a potential solution to do, and that is look at wellness programs, to look at access to healthy foods, to look at economic development, to look at programs so that individuals will be able to eat healthier, have healthier lifestyles, and then ultimately reduce the cost going forward, right? Because we can always have this conversation about who's going to be writing the check and where's it going to go. And I guess I'd prefer to not have to write that check to begin with. Where I live, so we're all in kind of different parts, I guess, rural, city, and then I'm in a suburban area of Dallas-Fort Worth. It's growing still at about 200 to 300 people a day in DFW, Arlington area. We're just growing. We have almost, it seems, every week some new company is moving, usually from California, coming to Texas. If you include from Plano to Grapevine, where I am, we've had J.P. Morgan Chase, Toyota, tractor factories, and so on. And so we're growing, and we're not having an access to care issue that maybe other parts of Texas are having. I live, on the road that I live, I had a health care forum with Congressman Burgess and head of the TMA at the time and others. And so I decided, okay, well, I'm going to go door to door to all the little doctor's offices on my street on this South Lake Boulevard, and I'm just going to invite them to it. Well, in about 2 miles, I went to 55 different medical places with doctor's offices, hospitals, and so on. So, yeah, if you're in the rural area, that's probably more than most counties, right? So we're not having that issue, but where we are having the issue is trying to figure out how, in my opinion, make sure that the rest of Texas has that same accessibility to that same sort of quality of care. And I just, in closing, I guess as a person on the Appropriations Committee, I'm just generally very concerned about how this growing healthcare costs, whether we sign up with more federal dollars or we no matter new programs that we start, it's going to just keep eating up our budget.
Thank you, sir. I want to, every single one of you alluded to, and this will be the last question I get to, but each one of you alluded to and discussed the issue of Medicaid, and I'm going to come back to that. But I want to hit on an issue that I know is critical to the folks here in East Texas. I know that it is an issue that is critical to the counties across the state, and that is mental health. Many of you discussed that in your responses, and in recognizing that whether it's in Tarrant County or Travis County, or the multitude of counties, Senator Colcourse, that with your areas of responsibility, but in particular, and Representative Howard, I want to start with you on this question.
Okay.
East Texas has a high rate of mental illness, and oftentimes law enforcement is serving as the first responder. The process creates a significant burden on county and local resources. And I think if you hear that just in East Texas, recognizing it, this is a similar issue in other counties across the state. How do we address this situation to make sure that the people impacted by mental illness receive the care that they need, and that the responders are equipped and counties and local governments are not overburdened? And I want to add to that question, too, about how do we address this from the coordination perspective, recognizing, too, that in the long-term care environments, you have so often there are residents with mental health needs that when they are admitted to a facility, there's difficulty in caring for them. But the challenge that many providers have is the lack of availability of resources back out in the community to find an appropriate placement for them so that their needs can be met. So all that being pulled together, how do we address the situation to make sure that those that are impacted by mental illness receive the necessary care and the coordination of care and the services that they should be getting?
And I'm going to start with that?
Yes,
Well,
ma'am.
That is a big one. I wish I knew the answer to that. There are a lot of things that we need to be doing. There are some things that we have done. I think it was mentioned a while ago about the mental health funding. The fact is that we have been more intentional and strategic about investing in that. And this last session, we also put money into a tuition assistance program specifically for mental health care providers at a certain level, had to be highly credentialed people at that level delivering in underserved areas. So, I mean, I think there are certainly some things that the legislature can do to incentivize getting more healthcare professionals in areas where we need them. The coordination, the finding facilities, that is a huge struggle, and I don't know that I have the answer for that. I think that we also have issues, as I mentioned earlier, with reimbursement that makes it difficult to attract people to this. It also, I think, makes it difficult to retain. And though we had an increase in a couple of areas in the provider, what am I trying to say, not the provider, but the people who deliver actual care to patients, to people in their home, to people who are infirm. We pay them at a very low rate right now. We bumped that up to try to address some of the turnover and the lack of being able to recruit people to those jobs. But it was a huge amount of money. I don't remember the exact number. To bump them up, you remember the number, Chris? I'm sure you do. To bump up just a little bit costs a lot, because we're talking about a very large number of people who provide home health and other services. They're paid at a minimum level. They don't have insurance themselves. And it cost us millions to bump that up just a little bit. It's like it gave them about $20 more a month or something. And that, is that what you put?
Yeah, $7.86 an hour.
$7.86 an hour to $8 an hour. And that was, I mean, they were thankful to get that, but that's not going to solve the problem. That's not, and we still have huge issues in all of our lower levels, I guess you could say, of healthcare delivery, where we're paying at such low levels and we're competing with everything else going on in the economy. It's wonderful what's going on in the economy, but it makes it very, very difficult to fill these jobs and to keep people in those jobs. And we're working with the most vulnerable people in our population. It is a huge challenge. And when we don't even provide insurance for them, the people that are providing that care, I mean, the challenges go on and on. So I don't know how to answer your question exactly, but you can see that it's multifaceted, many factors to look at. There is not one answer to this. We've got to look at it in a very comprehensive overview that looks at all the factors that are impacting how we deliver care. And that's part of what the commissioner's been doing, and his charge has been is to consolidate some programs, to look at how we can be more effective in our delivery, how we can be better stewards of the dollar. And I will say, in regard to what Representative Capriglione was talking about with the squeezing out of other things in our budget because of the increased cost of health care, if you keep the pie the same size and you change the slices, yes, that's going to affect things. I don't think you have to keep the pie the same size. That's just an assumption we're making here, that there's no way to change that. I don't subscribe to that assumption. I think there are ways we could address it to some extent, but I'll ask you guys. You know, we have had advances in medical care that have changed how health care is delivered. And Commissioner Traylor mentioned with Medicaid how a small portion takes a huge chunk of the budget. That's the same with any health care delivery. The 20% basically spend 80% of the cost dollars. If you have a family member delivering a premature baby, you want that neonatal intensive care unit there to take care of that baby. If you have a loved one who is suffering from a disease at end of life that you know that there are some things you could do to intervene, you're going to want to intervene. We put people in the position of making these very, very difficult decisions, but we now have health care delivery that can address things that we used to not be able to address. We all know that. We've extended life, and it's going to cost us a lot more to do that. The pharmacological products that we have now and the cost associated with those. So it's not as simple, I don't think, as saying, well, healthcare is growing and we can't do that. It's not sustainable. We can't pay for education if healthcare keeps growing. We have to look at what the models are that are going to allow us to deliver high-quality healthcare and high-quality education at the same time. I don't think Texans are beyond doing that. We just have to figure out a way to do it. Yes, it's going to cost us some, but we need to figure out what we want government to do and provide, how much it should cost, and then how we're going to pay for it. Let's have some honest discussions about that instead of starting off at the very end, which says we don't have enough money. I'm just not willing to go there. Sorry.
Thank you, ma'am. Representative Capriglione, any additional thoughts or comments on, again, how do we address the situation to make sure that people impacted by mental illness are receiving the care that's needed in coordination with the local responders? And
Sure. Well, in the 83rd session when I first started, I know Texas was ranked, it was 50th, right, in terms of per capita spending on mental health care in the United States. And I can't tell you what that number is now, but I know we've substantially increased that over the last 2 years. Guarantee we're still in the bottom quartile, right? And we know that what the benefits of doing that are big, not just in being able to take care of individuals, but all of the other factors that spills into both in public safety and all those other things. But when it comes to making those decisions, it isn't necessarily about keeping the pie the same size, right? The pie does grow, right? As our population grows and our revenues grow and our income grows, that pie does get larger. The question is how we're going to allocate those slices between those different line items. And the issue with healthcare, at least in the last budget cycle, is that the state of Texas did provide more in additional healthcare funding. The federal government's portion didn't grow as fast as Texas's portion of the healthcare. And so I think we have been committed in trying to provide that. The reality is we had election 2 days ago, Super Tuesday, and that's going to be part of what decides this in the next session, right? But a bigger factor is what happens this November. There's a lot of conversation going on in Washington, D.C., and the presidential election, I think, will help Texas decide. I know when we were working on TRS care, for instance, right, we had to make these decisions in terms of, okay, do we want to cut some of the options that retired teachers have with their health care program, or do we want to have them put in more money, have current teachers put in more money, have school districts put in additional dollars? Do we want to try and get them on Medicare instead? And what we ended up doing, and I think it was the right decision, what we ended up doing is saying, hey, you know what, we're just going to, for now, we're going to cover that gap, right? And it was $800, $700, $800 million, and we covered that gap. But it really is a stopgap. It is a short-term solution. And the rationale was we don't know what the healthcare system from the federal government down is going to look like starting in January of next year. So some of these decisions are kind of based on a bunch of different ways that this can go. But we do continue to spend dollars in mental health care, and I think that's one of the most laudable goals we have in terms of what we're doing with our healthcare planning.
Thank you, sir. Senator Kolkhorst.
We just heard the comptroller speak earlier today, and Glenn's a good friend. And when we went into last session, he gave us a $113 billion revenue estimate. He's already warned the signal that that is coming down, and he's taken away $2 billion, and he's going to continue to take away a little bit more. But here's the important thing that I think we did last session, and I want to say this in the whole picture of talking about pies. We had a $113 billion revenue estimate, and we could have spent it all. And one of the things that I fought very, very, very hard on, and I fought higher ed, I fought medical groups, I fought everything, was that I didn't want to spend all of that money because my instincts, I've served longer than anyone on this dais and probably anyone on the program today since 2001. I went through 2003 and went through 2011. Was that I just felt like we have a school finance lawsuit against us, and we're going to put more money into public education in some shape, form, or fashion. I was a little nervous about oil and gas. We didn't. We spent $107 billion. We left about $6 billion on the table, and that was the wise thing to do. So in the grand scheme of things is as we put more money into healthcare, like Gio said about TRS, we didn't solve anything. We just put a whole lot more money in it. And so the never ending, our pie is growing with our economy. It may have slowed, as Glenn said. I don't think that it's going to grow nearly 6% like it did in 2014. But what we must find a way to have a system, as Commissioner Traylor talked about, that we incentivize the consumer, us as human beings, that we get up in the morning and we exercise or we do something and we eat healthy, and the incentive should be that we want a longer and better life. But how do we incentivize the healthcare system to have a more holistic approach with the incentives of keeping people out of hospitals, which is our most expensive form of health care, but also to look at a continuum of care as we see that aging population. Representative Howard and I are dear friends. We're on different spectrums of how we view things about, and that makes us great partners because we fight really hard, but we came together on nursing home issues. But I will say this, in looking at Medicaid expansion, even though we have the largest percentage of people uninsured, even if we did Medicaid expansion and we have the exchanges, we still are going to have the largest number of people uninsured in Texas because of the undocumented workers or the illegal aliens that we have here. And it's a tough issue because we're a border state, and we're the biggest border state in the United States. There is no bigger border than the Texas-Mexico border, not in Canada, not any, on the other border states to the south. So the challenges are there, and they're large, but I think that there is going to be, like Gio said, a new president of the United States. We do know that. We just don't know who it's going to be. But if I could go up there and I would tell Congress, I would tell the President of the United States, I would tell anyone, I would tell the Donald, whatever, here, this is what I'm going to say. Please block grant us the monies for Medicaid. Please send those dollars to Texas without the strings attached, and watch how creative we become, and we'll cover more people. I promise you that we will cover more people. We have seen it with the DSRIP projects in the 1115 waiver, how we had competitors come together to pull down federal dollars and actually work together instead of competing against each other. There's always going to be competition. I believe in capitalism. But if I could get the federal government to say that the 1965 model doesn't work, the entitlement model, say that we have to use it on health care, but let us in Texas address the problems. East Texas is very different than South Texas, and South Texas is very different than the Panhandle. And you have been blessed today to see people from all over the state of Texas come and visit with you about their ideas. And I'll tell you, it will be the one thing that dramatically changes the trajectory of health care expenditures and healthcare outcomes in the United States of America for forever, if we could get them to block grant the monies and let us go about it the way we see fit in Texas for the different regions of Texas.
Thank you, ma'am. Commissioner Traylor, any thoughts on mental illness, mental health?
Yeah, let me kind of compartmentalize this to something I think needs to be touched on, and
Please.
that is the links to the criminal justice system.
Thank you.
And there's a couple of programs in the state that I think could be modeled well. One's Haven for Hope in San Antonio, and then there's another project in Cameron County. And what they've done more than anything else, they've trained police officers and sheriff's departments on how to deal with people during a mental health episode. And it has done more for the quality of life for those people with mental illness, as well as their families, as well as the police departments who aren't having to jail individuals. They're getting them the mental health first aid and the mental health services they need quicker, better, and it's relieved the jail burdens, and it's relieved a great deal of angst from county officials who were at a loss on how to deal with this population. And it's without going into great detail on it, I think that the linchpin of it is training police officers that respond during mental health episodes. And those are two outstanding programs that I think that could be replicated throughout the state. And as Senator Colcore said, those were programs that were allowed to develop independent of federal rules, regulations, or edicts from the state. Those programs were developed organically, and they've worked very, very well. And I think that's an example of how block granting or allowing folks to work together at the local communities can have a tremendous impact on people at the local level.
Thank you, sir. You said Haven for Hope was one. What was the second one?
It's Cameron. They don't have a name for it in Cameron County, but
Okay.
it says it's the Tropical Texas Mental Health Authority has a project that is largely operated in Cameron County, but some in Hidalgo too.
And if I can just add, part of what those programs and other efforts like that, I'm really glad you brought that up, Commissioner, is that it's also making sure that with that training that people go to the right facility instead of being incarcerated, which is not necessarily an appropriate solution when you are having a mental health crisis. And it really is making a huge difference. And we're also seeing a lot more de-escalation training for healthcare professionals across the board. But I'm totally, this is one of the things I think that could be very important.
Thank you, ma'am. We've got about 13 minutes left, and this is the question, again, I think all of y'all hit on, and I'm not really sure who to ask to take the lead on it, so I'll ask the question and then kind of open it up. But I want to come back to, this is a question about healthcare finance, and I think when I look at all of you all's responsibilities, whether it be Senator Colcourse not only on Senate Health and Human Services, but also on Senate Finance, obviously, Commissioner, with your responsibilities, Representative Howard and Quickly-Owned with your responsibilities on appropriations. Here's the question, if I could. As we look forward to the upcoming session, we've heard concerns, and it was discussed at lunch, we've heard it at other times about future revenue projections. At the same time, and it's been mentioned here as well, the legislature will in all likelihood need to address issues such as the school finance issue, such as, and then continued efforts to address tax reform. So with those in the air and those issues among others that have to be addressed with respect to healthcare finance, where does Medicaid funding fit as a priority? within those discussions. It's the largest component of Article II budget and the most significant funding source for so many providers. We see, and again, you all discussed this, we see issues of providers that are either unwilling or unable to care for patients under Medicaid, which ultimately leaves access issues. It causes workforce issues. How should the legislature address the current Medicaid obligations while ensuring that the resources are available in the future, particularly as our population continues to age and as we are responsible for a much broader population in the state of Texas?
I'm going to say one thing, and then I'm going to give it to them. The only flexibility we really have in the Medicaid program is rates. And that's where we go to too often. I know that we'll look at doctors' rates and we'll say, well, you know, it's this many billion, and so we're going to cut that, and we're going to cut that, or nursing home rates, or whatever. That's where we go to is rates, because there's no other flexibility in the program because of, you have to ask permission, and Chris can speak to this. You have to ask permission from the federal government, CMS, Centers for Medicare and Medicaid, to make changes to any program. And you can do that informally, and you sometimes get some answers. But then you have to do it very formally in the process of a waiver, which means that it waives the federal rules. That's what a waiver means. It means we're going to waive these federal entitlements to allow your state to do something. So even something as simple as a pilot program that you could say to someone, and I've always said this, you know, I'd like to load a card up like we do maybe even food stamps and say, okay, now we're going to this one little population, we're going to let you, you know, allow yourself to have this debit card to pay for your health care, and then, you know, at a certain point, then it all can't do that. I can't do anything. I cannot come up, I can't pass a law, convince Donna Howard and Gio and the House and my Senate colleagues to do something, because the federal government tells us what you can and can't do with those dollars. So the only flexibility they give us is on rates, and that's where we always go to, because that's what we're forced to do. So if the federal government, CMS, and I'm not talking about who the President of the United States is right now, or I'm not talking about who, you know, is in Congress, if they could all come together and say, we're going to waive these issues, we're going to block grant these issues, even if they did it for a period of time and said, we're only going to do this for 5 years to see if you're behaving well, I'll accept that. But we can't get it. And we've sent waivers up there. I've passed waivers. I've done the healthcare compact. I've done everything that I can to signal to the federal government, just give us a chance and we'll do it. So that's my 2 cents. We're going to keep cutting your rates until we get flexibility. Once we get flexibility, we'll be creative with the providers, some of which are sitting in this room, and we'll come up with better ways, and we won't have to cut the rates of doctors in nursing homes and hospitals.
Oh, I'm going to jump in. I think that I agree with a lot that Lois was just talking about, and I think we have had some opportunities, and we do have some opportunities before us when we come back next session to do some of the things that she's talking about. You know, clearly anybody who holds the purse strings over somebody else has something to say about how the money is spent. We at the state level do that to public education. We don't just give money to public schools. We tell public schools how they have to spend it. Local control, there's not very much local control. It's pretty much mandated how things are done. The same is going to happen when the federal government is providing money to the state. There's going to be a certain amount of parameters of how the money can be spent. That being said, flexibility is especially important in a state like Texas, where one size does not fit all. We are a huge state. There could be